Good afternoon, everyone, and thanks for joining us today. My name is Jarrett Casanidi, Coordinator for the AIDS Education and Training Center's National Center for HIV Care in Minority Communities. Before we begin today's web conference on advanced access, what's it all about, I'd like to introduce you to today's presenter, Catherine Tantau. Catherine is an internationally recognized authority on access, efficiency, and flow systems in healthcare. If you'd like to ask a question at any time during the conference, please click on the chat button and type your question into the chat box. Alternatively, you may click on the raise hand icon and we will unmute your phone line and invite you to ask your questions before the group. I'd also like to remind you that we do have some documents loaded into the WebEx interface that you can access by clicking on the document at the top, the tab at the top, and then going to File, Save As, and then choosing Document. And this way you can download the documents that Catherine is describing in the presentation. So without any further ado, Catherine, would you like to get started?
Absolutely. Thanks so much, Jarrett, and welcome everybody. It's great to have you back on the line again. These weeks are going by quickly, and I realize this is our third of 10 webinars that we're going to be doing about access. So again, welcome, and we'll get started right away. The topic today is really an overview with some detail about this advanced access model. We've been very busy for the previous 3 weeks looking at, how do we create an aim for access, how do we do the baseline measures that are so important to let us know whether or not the changes we're making are resulting in improvement. And this is really, today's call is really about understanding the background and sort of the philosophy, but also some of the how-to, sets the stage for really learning more about how to actually go from whatever your current delay is to your goal. We'll touch briefly on some of the resources that are available. Jarrett mentioned those. One of the things we know certainly is that people like yourselves who are often tasked with bringing the message back to very busy clinical areas. That's, I think, almost the toughest role of all. And so we wanted to make sure that you had plenty of resources available to you as you bring that message forth, whether you're currently doing it or it's something that you'll be doing in the future. So you'll see lots and lots of things to help you along the way. This, again, is just a view of where we are currently. And we're here on January 31st, AA Advanced Access, what's it all about? And then we'll follow up again next week with a question and answer coaching call so we can really drill down in more detail. This is one of my favorite Herman cartoons. I just love Herman. So often we find ourselves stuck in systems that are poorly designed, not because anybody wanted them to be poorly designed, but it's just sort of what evolves, and we're struggling to hang on, and somehow we get accustomed to the way we're doing business, recognizing that it's broken, it may not be perfect, but nevertheless we accommodate it. Well, this is an opportunity to really change that, not only for your patients, but certainly for yourself. Our objectives for today are to, first of all, recognize and be able to identify what we refer to as the gold standard for appointment access, and to learn the characteristics, pitfalls, and benefits of 3 different access models. And the reason we like to do that is because it's almost a historical view of how most clinical teams migrate from what we refer to as very traditional models through carve-out models and then to advanced access. One of the objectives that I didn't put on here, but certainly is part of today's call, is to touch base and see how people are doing. So towards the end of the call, we'll have some time to review any questions that you might have in terms of your measurement or things that you've already, your aim, and any of the things that you've already started working on. I touched briefly on this messenger challenge, and I really would like to reiterate it. Of all the work that is being done with advanced access, taking the information back is certainly at the top of the list in terms of most challenging. So our goal is that this become a little bit easier for you. We've got a number of resources. Certainly all the presentations that we'll be doing throughout this series are available to you. And today in particular, we have loaded Advanced Access, What's in It for Me. And let me just hit that tab. Let's see. Sorry. Let's click on this. So this, please feel free to print this out. It's kind of from a provider's perspective. Why would I want to do this? What's in it for me? We're not going to go through the detail now, but just put it in your workbook, in your catalog of resources that potentially will be useful to you. And then here's another part of our information series, What is Advanced Access? And it's a very simple, these tend to be very short papers that we've put together. This one is a single page. If somebody has questions, what's Advanced Access, you can print this out for them, give it to them to read. And it's a great way to start a conversation if you're, when you're moving towards improving access. And then finally, this is an article that we wrote. It was published in the Journal of Ambulatory Care Management, and it's all about accessing patient-centered care using the Advanced Access model. And we cover quite a bit in here and have some real-life examples of what other groups have done, both in primary care and specialty care and community health centers, in fee-for-service practices. So there's a wide range of experiences. And again, as you embark on this work, we find that this is a great resource for people. So, okay. So let's move forward. This is really the basic question that we like to ask teams when they're getting started is, imagine if you could offer your patients an appointment with the physician or provider of their choice at a time that was convenient for them, for the patient. And when I'm in a room full of people, what I can always spot the receptionist, because they sort of get this blissful look on their face, you know, because they're right there in the front line having to deal with the concerns that patients have, as well as providers and staff when we can't get patients in on time. But just imagine for a moment that if you actually, at your center, could do this, provide patients with an appointment with their provider of choice at a time that was convenient for the patient. It really would transform things pretty dramatically. Here's some comments that have been made by a variety of physicians who have embarked on this journey. The first one was a fellow who, oh gosh, I didn't put his name here. His comment, nevertheless, was, I had to think about this for a while before I jumped in. And what he's referring to is his move to advanced access. I realized that everything in medicine's changed steadily. We're constantly looking for better ways to diagnose and treat patients, but office flow stayed the same for 50 years. It's about time we pay attention to it. Now, this was a practice that had a waiting list of 4 months, and this physician had been in practice for 26 years, and the waiting list was fairly steady at 4 months during most of that time, except, of course, when he started. And he got rid of that 4-month delay over a 4-month period. And in a few weeks, when we talk about backlog reduction, you'll learn what were the strategies that he and others have used to effectively eliminate that delay. But he's been living with this 4-month delay literally for his entire career, and was very successful in eliminating that. Here's another comment by another provider. Minor changes in flow can help greatly with a very busy schedule. And this was a provider whose third next available, as you all know, the anchor measure for delay, was 15 days. So quite a difference from the first comment. It was a 15-day delay here versus a 4-month delay here. But nevertheless, they reduced their delay from 15 days to 5 days. They chose that as an aim, not what we would necessarily recommend for a lot of different reasons. Might as well go for the gold. But what was curious was that in this practice, they also took 4 months to reduce their delay. They had a much shorter delay, and they did it over a 4-month period. So again, when we talk about backlog reduction, we'll talk about the pluses and minuses. You know, what are the advantages of getting through this quickly versus more slowly? And then finally, a provider who said, I've seen that this works in other places, so we've adapted the principles in our service. And the real key to this is understanding that every practice is a little bit different. There certainly are similarities, and we really try and focus on the general principles for improving access. But there are lots of strategies that you're going to hear about over the next several weeks that may need to be adapted to your unique situation. And we really encourage that. You know, you'll be going through a process of testing changes, and you keep the ones that work, and the ones that don't work, we move on. So this concept of adaptation is really important, and frankly, it's added to the richness of the strategies and tools that we now have available. So an access problem is a delay problem, and it tends to be a system property. It's not about bad staff or overly demanding patients. It really is how we've designed our system over the years, perhaps unwittingly, but nevertheless part of our design. One of the things that we observed early on, and we see this, frankly, wherever we go, is the reality is the longer patients and families wait, the harder we work. And this is a flow diagram of patients simply trying to get through. This happens to be a community health center in New York City. Patients trying to get through on the phone to book an appointment, whether they're a new patient in this column or they're an established patient calling back. And the only difference is the new patient simply gets tossed into the same queue as the other patients. We're not going to obviously go through the details of this diagram, but suffice it to say that this was a group, like many of you, who are desperately trying to get the phones answered. The phones are ringing off the hook. Many patients are calling back because their problem or issue or request wasn't resolved in the first call. Messages are flying back and forth, whether they're on paper or electronically. There's lots of stuff going on, lots of people weighing in to see, you know, can we get an appointment for this patient, or can we get it for them sooner? So lots and lots of people, lots of handoffs, lots of opportunities to lose messages and lose requests, and a tremendous amount of work going into simply get an appointment. So because frankly, the person on the phone so often doesn't have what the patient's calling for. In many systems, we see they're out of appointments within the first 20 minutes or half hour of the day, and then they get tossed into this labyrinth trying to take care of patients. So we're working pretty hard when we're sustaining a delayed system. Again, an access problem is no delays for an appointment, it's continuity for patients and their providers, and it's all about doing today's work today. It is not, and these are all strategies we've used, it is not holding appointments in anticipation of same-day urgent demand. It's not a walk-in clinic or an urgent care clinic. It's not even a schedule that's 100% open every day. And it's certainly not about telling patients, please call back tomorrow when we open more appointments. So while these are stages that we often will go through, what we really want to get to is this reality over on the left. It's the ability, to, again, to offer patients and families an appointment with the provider of their choice at a time that's convenient for them. So this gold standard that we've touched on in several calls is probably a familiar statement to you all now, and it's to offer an appointment today for any problem, whether it's urgent or routine, with the primary care provider or teammate in the absence of the PCP. It doesn't say when the PCP schedule is full, it's in the absence of the PCP. Now, for those of you who've worked on panels, and I know many of you have been actively engaged in that, you have already equitably distributed patients using the panel methods. And so having laid the groundwork, now providers come in responsible for, instead of the 15,000 patients who access your center, perhaps the 1,500 or 1,200 or whatever the number is that are aligned with a particular PCP. It really changes the work of the providers and their care teams. Nevertheless, it's very easy to feel overwhelmed with this notion that we would have to do or be able to do or strive to do all of today's work today. Pretty scary thought. So the question that people say is, what's so great about today? You know, our patients just want to get in, and they'd be happy with 3 days or 5 days. And so there are a couple things, and I'll show you some data in a bit that's kind of interesting, that how when we commit to offering to do today's work today with patients, the number of patients that actually are thrilled and delighted, particularly if it's with their PCP, and everything just sort of calms down in a very interesting way. We find in pediatrics about 80% of the time families will accept today, and in adult primary care, once they get used to that offer of today, it's about 75%. And that reliability is actually works in our favor. But back to why today? Why this gold standard of today? Well, we have historically approached our work dividing patients in 2 buckets. Well, 3 really: urgent, routine, urgent, and emergent. And of course, the emergent patients we send to an emergency room, a venue that's equipped to take care of emergencies. So then we're left with both the urgent and the routine care. And in our wisdom, you know, whether we're doctors or nurses or medical assistants, we have a sense of what qualifies as an urgent appointment versus, which needs to come in today, versus a routine appointment that can wait. The problem is that medical definition simply doesn't match up consistently with what our patients tell us or how they see the problem. Today could be the day they have transportation. It could be the day they have an interpreter. It could be the day they're off work. It could be any number of things. And so there is an urgency, and we sort of it's very difficult to accommodate them if we're driven by our strict definitions of what's urgent and routine. So the opportunity for patients to call or even walk in today and be offered that appointment today is lovely. But beyond that, what an advanced access practice is able to do is, frankly, be transformed. To come to work every day and know that you've been able to predict demand for appointments, and you're pretty consistently arranging your supply of appointments to match that demand, really transforms the practice. So that very busy slide that we saw a little bit, you know, the phone slide where people are calling and there's all those handoffs, a lot of that work simply goes away. The interruptions to the provider, where do you want me to put this patient today? You've predicted demand, you've deployed supply, and you can really focus on caring for patients as opposed to managing that schedule in a crisis mode. There's also room to grow the practice today generally, not in every case. Occasionally we find practices who have more demand than supply, and growth isn't necessarily their desired outcome. But for those who want to grow, there certainly are opportunities to do that. And if you're in a competitive marketplace, it's clearly a competitive advantage. This is an example. This was actually a community health center in Providence, Rhode Island, where you can see in pediatrics, OBGYN, and internal medicine, in all 3 of their departments, they were committed to improving access essentially to 0 days, and they did that very successfully. And you can see how the numbers tumble down from a 40-day delay to an 80-day delay when they start, and then actually hit this baseline of essentially 0 days delay in all 3 departments. Really impressive work. And you'll see some explanation of this work actually in the article that the Journal of Ambulatory Care Management article that is available to you. At the same time, at this community health center, Capitol Hill, they saw a 50% drop in their no-show rate, which has turned out to be a wonderful, although unintended, consequence of getting rid of delays. So I'm not going to spend too much time on the next couple of slides, only because we've spent time talking about how we measure third next available, which is the anchor measure for delay. But I just wanted to include it in here so you had kind of a complete package. So I'm going to go through these, and while I'm simply showing these on the screen, let me just take a moment. If you have a question, please feel free to chat it in or raise your hand, and and we'll address that again, whether it has to do with this anchor measure or anything that we've talked about so far. Please feel free to raise your hand. Okay. Well, while some of you may be formulating a question, I would like to bring your attention to this particular slide. This was some of the early work we did, and you can see it was in 2003, where we began to expand the notion of advanced access beyond primary care and specialty care. And what we realized was that in this case, we were working with a group that said, we can get our patients in today, but the imaging department can't. And so when the patients are here, we decide, someone needs a mammogram, a screening mammogram, certainly diagnostic mammograms, they're often going to work them in or double book, the same things we do. And they said, wouldn't it be lovely when patients are here, if before they leave they could get their mammogram? And so this was some of the early work that we did in imaging to say, yeah, let's apply these same principles to lab, imaging, pharmacy, any place where patients are left waiting. And so you can see a 25-day delay for a routine screening mammography down to 0 days. And there now are a number of groups around the country that do this. It's pretty spectacular. It certainly makes things a life easier for everyone. So we started to see this and really support groups in this expansion of this notion that there's rarely value in delays. So what I'd like to do now, and I'll stop here again to see if we've got questions. Jared, I don't know if you are spotting any or if we see any hands raised.
Yeah, I don't see any questions now. But again, I would encourage everyone who's listening to take advantage of being able to ask a question directly to Catherine and get some feedback.
Great, thanks, Jared. So what I'm going to do now is take a look at what we consider the 3 critical design elements for a good access system. And the first one is continuity. And in primary care, of course, that's continuity between patients and their primary care provider. The second one is what we refer to as appointment capacity. Do you have room? Do you have space? If you close your eyes and think of tomorrow's schedule, is there room, space to put patients who want to be seen? And then finally, and interestingly enough, this was not one of we did not initially 15 years ago identify this as a critical building block. We knew that demand and supply of appointments had to be in equilibrium, but we thought if you measured it once, that was fine. And of course, what we've learned is that it's a continuous measurement. So very, very important because so much changes, both in terms of demand patterns in your practice as well as supply patterns. So we're going to talk about each of these design elements. This was an early study that was done, happened to have been done at Kaiser in Northern California. Lots of groups have replicated this study, and what we found was pretty fascinating. This is long before access was even on our radar screen. And what you're looking at here are about 70,000 primary care visits and the levels of patient satisfaction depending on who they saw. And the data was sliced and diced but in a number of dimensions. The ethnicity of the patient, their gender, their age, their educational status, their health status, the type of care they were receiving, the number of visits they'd had, and their tenure with the organization. So again, looked at it through a number of dimensions, but the patterns were stunning. They were so consistent across every dimension. The highest levels of satisfaction when patients came in for primary care occurred, and you can see that with the blue lines, when patients saw their PCP. And that's kind of a no-brainer. It's what we would expect. I have a PCP, I like my PCP, that's who I want to see when I come in, and when I actually get to see that person, I have higher levels of satisfaction than when I see, and the red dots and lines indicate I've seen not my PCP but a teammate, someone that's familiar, someone who may be right down the hall from my PCP, someone that I may have seen on other occasions. And receptionists will tell you patients are very willing to accept that offer of someone else, particularly if they want to get in sooner rather than later and their own PCP is not available. And it's typically the second question they ask, well, who else is available? So do patients accept that? Yes, but what really stunned us was that there is across, again, all of these dimensions, about a 10% drop in satisfaction. Very consistent pattern. And then finally, the lowest levels of satisfaction, again, across all of these dimensions, lowest satisfaction occurs when patients see someone that they would describe as a stranger. And typically we see that it's an urgent care venue, it's a drop-in clinic, it's a walk-in clinic, and the system simply isn't able to match them. We've determined they have an urgent need, and patients might describe themselves as, I'm ill, I'm sick, and I'm vulnerable, and now I'm farther away than ever from my PCP. So again, it's not surprising that their levels of satisfaction, frankly, plummet. And this is where we were when we developed this model. We had access to some of this data, and we thought, wow, continuity has definitely got to be part of what we do. And we've talked about continuity. It's simply the rate at which patients see their primary care provider when coming in for a visit, and all the good things that happen when we have good continuity. You know, fewer hospitalizations, shorter length of stay, and the list goes on. And interestingly enough, it lowers the demand for appointments. So if you're struggling with high demand numbers, the ability to match patients with the PCP consistently is critical. And of course, satisfaction improves across the board. So continuity is really, really important. The second key building block we found was we referred to as capacity, and all that really means is, do we have appointment supply? Do you have sufficient appointments next Monday to be able to offer patients an appointment that day with their PCP for any problem? And this is a look at a group that, and we're looking here at a 4-week snapshot of appointments, the percent of appointments that are open in the next 4 weeks. This was a group that started with 3 providers. They had between 5 and about 10% of their schedules for the next 4 weeks were open and available for booking. Everything was booked out into the future, okay? So probably not unlike some of you. And what we saw happen was, as their backlog came down, or as their delay came down, you started to see this improvement in the percentage of their schedule that was open over the next 4 weeks. And I really want to warn people, this is not about shooting for 45% of your schedule being open. This is simply an example of what worked for them. And it happened not because they were freezing schedules or holding schedules, but because they were increasingly able to do more of today's work today, and the work didn't drift onto their future schedules. We'll talk a little bit about how that's possible. But, you know, again, thinking about where do things really start to open up and what percentage of your future is open for booking any kind of problem is kind of a critical thing you want to look at. Here's another look. This is actually the work that was done at South Central Foundation. These are the folks that we worked with a number of years ago, and they ended up on the front page of the New York Times with their amazing access work in primary care. So they started with less than, somewhere, less than 10%, definitely. And again, as they got better and better at this, you can see they got up to 56% of, in this case, they're not looking at 4 weeks, they're looking at what was open at 8 o'clock in the morning. Now they run in 75, 78, 80% of their schedules are open. There's some patients that are on the schedule. They've been pre-booked because that's what the patient wanted, or there was a clinical need to pre-book them. But most of their schedule is open and available. So again, change things pretty dramatically. So do they have appointment availability or capacity? Absolutely. And what that allows them to do, this is where access and continuity really come together. You cannot have good continuity unless your providers actually have the capacity on a daily basis that each of them need to take care of their patients. So you see this really dramatic increase in continuity from, somewhere around 15% up to, higher, 75, 77%. Very dramatic. So patients are consistently seeing their PCP. and I know we talked a little bit about that last week, again, it quiets down demand when we're able to do that, when we consistently match patients with their PCP. So let's talk about our third critical design element, and it's this business of appointment demand and supply equilibrium. So the image I like to use is one of, we've got this lake here, and we call it the lake of delay. And we have patients who call in or walk in requesting an appointment. So we have demand for an appointment. And if you're really sick and you can prove it, we offer you an appointment. We figure out a way. We'll get you in here somehow today, whether it's, you know, overbooking your primary care provider, or it's seeing a colleague, or we're sending you to urgent care clinic. Whatever it is, we figure out where we're going to get the supply to see you if you're sick and you can prove it. And it meets our criteria for urgent. Everyone else pretty much goes into this lake of delay, which simply means they're on this, offered an appointment in a week, in a month, whatever it is. When's the next available appointment? The problem is that if this delay doesn't match with the patient's desire for that appointment, they frankly don't wait quietly. There's lots of things that happen, lots of rework. We know that no-shows go up. We know that there's, of course, a lot of triage that happens, sometimes more than once, as patients call back because that appointment we gave them really doesn't work for them. The staff is doing more rework, handling more callbacks, creating more messages. There's more testing that goes on and more prescriptions that are written. I mean, it's just we try and do stuff simply to keep a lid on this delay that frankly isn't working for the patient and is creating a lot more work for us. One of the things that I like to encourage practices to do, and I would ask you just to take a moment to do this. We ask the question, do you have evidence of a stable lake or a stable reservoir? Is the demand flowing into this lake equal to the supply? And some of you have started to measure that, so you know whether there is or not. But there's actually a simpler way to get a general impression. And the question we ask is, what's your delay today for routine care? And, you know, just take a moment to think about what your current delay is. And then ask yourself, what was it a year ago? What we find more often than not is people will tell us it's exactly the same. It's always been 3 months, or it's always been 2 weeks. And that sort of brings us to the conclusion that there's not much we can do about it. What that actually tells us, and frankly, I don't care if it's 2 weeks or 2 months or 10 months, what it tells us is that you probably are in equilibrium, that your demand and your supply are in equilibrium. You're just 10 months too late. So it's not a bad thing at all to say that's what it is and that's what it's always been. It really, again, that's sort of a back of the envelope, let's get an impression of what's going on. And you really want to follow up with your appointment demand and supply measurements. But it's an interesting question to ask people and see what the answer is, because indeed you may actually be in equilibrium. It just doesn't feel like it because you're battling that additional supply. Where in the world are you going to put people on top of an already jammed schedule, which becomes, you know, obviously very, very difficult. So again, let me just stop here for questions, comments, or experiences that people have had. Please feel free to chat or to raise your hand. We've talked a lot.
Yeah, Catherine, I'm not seeing any questions, but looks like Connie Bishop, you've got a question, and would you like to, let's see, would you like to speak it to the group? Right now, I'm not able to unmute your phone line. I can't determine exactly which one yours is, Connie, but if you chat it in the chat box, I'll read it off. And we are getting a question in from Emma Harrell. She says, she asks, how do you define routine care?
Ah, great. Okay. So generally what we think of as routine care, frankly, is anything that doesn't have a sense of medical urgency about it. So it might be, typically people will say a physical might be routine care. Again, not a lot of urgency about it generally. Might be somebody who says, I've had knee pain and I've had it for 2 months. And, it's pretty much the same, no sense of urgency about it. So things that we would typically say from a medical or nursing perspective, this is something that can wait, versus I think I sprained my ankle, I've got, severe abdominal pain, I've got, my child is crying and screaming, and we've all had strep throat or ear infections, the kinds of things that we would fall back on in terms of medical definition. And those are pretty widely accepted. There's not a lot of variation there. So hopefully that answers the question for you, Emma. And I think
Emma.
Oh, go ahead.
Oh, Emma does have another question, and Emma, I'm going to unmute your phone line, and you can ask the question directly.
Okay. Can you hear me?
Yes.
Okay. So I guess my question is, we currently do have slots on our schedule. We have green for open access, quote, and yellow, which I think would be what you refer to as probably the routine care. But if we're trying to have it open, we really should just have all of those slots open, and then you wouldn't be able to count to that routine care slot, correct?
Exactly, because frankly, if you're moving to advanced access, it doesn't matter.
Okay.
We don't care if it's routine or urgent. If you do your appointment demand forecasting, it doesn't matter.
Right. So if we get
the work that goes into triaging simply goes away, because we want to get out of the business of trying to decide who should wait. We want to be positioned to offer that appointment today for any problem. And the only way to get the confidence to do that is to actually do the demand forecasting measurements that we talked about last week. Otherwise, people are terrified. They just can't imagine that anything like that would be possible. And we're going to talk in a minute about one of the reasons people think they have to hold slots, hold X number of slots for same-day urgent care, why that particular model, and it's listed here as a carve-out model, why that actually doesn't work long-term. So perhaps as we move into that, it'll make a little more sense.
Great, thank you.
Sure, it's a great question. I think there was another question here from Connie that I'm spotting. Can you do advanced access without age, gender weighting of panels? And what is lost if you do? And you absolutely can, Connie. In fact, lots of groups around the country haven't, they just have simply divided up the number of patients by the number of clinical FTEs, and they haven't yet or choose not to use age and gender weighting to weight the panels and that's perfectly fine. The main thing is that whatever methodology you use for empaneling patients, that we all agree within your organization that we're going to approach it in the same way. But early on, we had no such tools as age and gender weighting, none at all. It was simply a matter of, and this was really driven by our providers. They said, we're willing to work hard. We think this is a little nutty, this advanced access thing. Of course, we didn't even call it then. We called it, what did we call it? Patient-driven access, I think is what we originally called it when we were developing the model. And the providers that worked with us said, okay, we'll give this a whirl, but we just want some reassurance that if we have really good access, our reward isn't going to be our colleagues' overflow because their access isn't so great. And so we simply divided the patients fairly and equitably among the providers with no age or gender weighting whatsoever. But so that's one of those refinements that's come along over the years. So, but don't let that scare you. Just because it's out there as a potential tool and for whatever reason you can't do it, it's fine. Move forward. It's not a fatal issue by any stretch of the imagination. So those are great questions.
Great. Thank you, Catherine. And Connie did have a follow-up question. She asks, what is a benchmark for continuity?
So continuity, the best that I've seen in a couple of settings 90% plus. That's pretty rare. I more typically see in the 80s, 80%, 82%, 85%. And remember, this is a measurement that we're doing month after month, so you want to put it on a run chart. If somebody's gone for a month, that month their continuity is going to be 0, right? There's no way their patients are going to be able to see them. Or even if they're gone for a week, their continuity will be less because they're gone. So the main thing is to see how can we improve that number over time. But unless you have, you know, saints working for you who are working every day of the week and never take time off, then we're not consistently going to hit 100%. But certainly in the 80s is wonderful. Even the high 70s, 78, 79, it's wonderful. It's wonderful.
Great. And we do have actually 3 more questions. So I'll take them as they came. Andrea writes, how do you build follow-up appointments for those in need of chronic disease management into advanced access, open access, an advanced access, open access schedule?
Yeah, great question. So remember that when you're doing your appointment demand forecasting, we're not only counting patients calling us who want to be seen or walking in and want to be seen, but we're also counting those patients who leave with a return appointment booked and in hand. So we're counting every appointment booking transaction that takes place. So what's folded into your total demand number for appointments will by definition include that internal demand, those follow-up appointments, as well as patients who are initiating the call for the appointment. We just don't need to distinguish between the two. So whether patients decide to call the day they want their follow-up, or you decide that you want to send them a reminder that they need a follow-up for a chronic disease problem, or you want to book it before they leave, those are all options that are open to you with advanced access. The most important thing is to understand how big is the bucket of appointments that you need for each provider each day to be successful.
Great. And let's see, Javier asks, do you have any recommendations for centers that work with homeless populations? It's sometimes difficult to establish continuity and predict demand.
Yeah, that's a tough one. We did a lot of work with the Puget Sound Neighborhood Health Centers in Seattle, and one of their centers at the Pike Street Market was primarily a homeless population. And they had fluctuations in demand, but they still were able to see patterns. You know, Mondays were always busier, so patterns did emerge. I think the bigger issue, frankly, is continuity, because many patients pass through as a one-time visit only. Others may be there for a few years and not come back, and then a few years later come back, and so it's a bit of a struggle. So what you want to do is sit down as a group and say, given the unique characteristics of the population that we're serving here, the homeless, and of course the majority of them are walk-ins. You know, it's not like they're making a phone call and booking ahead. So what we often find in those situations is that advanced access works particularly well because you want to be mobilized on a daily basis to see whoever shows up, because, as I said, they're not often going to book an appointment in advance. So your most important ally is to say, let's do what we can around measuring the demand patterns, find out when we're busiest and when we're less busy, and then have a discussion about who's open and available based on panel size to see the new patients when they come in, so that we don't have patients bouncing around the system, recognizing that in a homeless population, patients may not be on a panel as long as for as long a term as they might be with a more stable population, you know, a suburban or a population that actually is not homeless. So those are some, you know, when we talk about how do we adapt things, that's a really good example of some of the things you might try to adapt. But again, you still want that fair and equitable distribution of patients. It's really important for your providers and your care teams. So hopefully that helps.
Great. Thank you, Catherine. And Sarah asks, if you do your demand and supply measures and find that the scheduled appointments match the supply each day, but you're still deflecting a lot of appointments. What does that mean?
If you're deflecting them, well, and it sounds like you're using the table that we introduced last time, which is great. So you have some patients for whom you're not able to meet the full demand. We don't count it in our total demand because very often we deflect the same patient multiple times. Call back tomorrow, go to urgent care clinic. Do they really go to urgent care clinic, or do they call you back later, or do they walk in? I mean, it takes many different scenarios. But as your access improves, so I understand that you would clearly have some concern because you really don't know how much of that unmet need is out there, how much of that unmet demand. You know, you might know it happens once a day, or maybe it's happening 20 times a day. But as you begin to use the other strategies and you begin to see your delay come down, what you'll notice at the same time is the number of patients you're having to, and as you establish panels, the number of patients that you have, or the times that you have to deflect patients is going to start to decrease. It's going to start to diminish. So you're going to be working on some of the other building blocks. And what you'll find is that that will slowly come down. Unless, for some reason, there's a surge in demand in your community, and so your actual demand numbers are going up. So it sounds like you may be one of those organizations where you potentially have some concerns about more demand than supply. And as we talk about more of access strategies, we'll spend some time talking about when that does happen. Things like optimizing the care team, things about reducing demand for visits become very, very important, so that you actually have a fighting chance of reaching your access aims. But your strategies, you're going to emphasize some strategies more than a group that actually has ample supply. So let's move on here. I want to talk about these three models for access, only because they tend to mimic a journey that many of us have taken. And this was certainly our journey 15 years ago, and I see it over and over and over again. What I'd like you to think about is it's kind of a continuum from a traditional model to what we call a carve-out model to the advanced access model. And as I'm speaking, think about where you might fall on this continuum, and frankly, where you'd like to be. So let's talk first about a traditional model. And usually at this point, I'm writing on a flip chart, and we do a lot of diagramming. So I'm going to try and do my best to describe what this looks like. And I'm sure for most of you, it'll sound familiar. In a traditional access model, you've got schedules that are completely jammed. They're completely full. They may have been full for a week. They may have been full for a month. Whatever it is, there's no place to put patients who we know predictably are going to want to come in when Monday rolls around. We know we're going to have more demand, but we also know that our schedule's completely jammed. They require a tremendous amount of triage and rework to figure out who's urgent, who's routine, where are we going to put these patients, what in the world are we going to do with them. So lots of work on the part of the staff. We often try to manage this mess, if you will, by having multiple appointment types, by putting caps on the number of physicals, or the caps on the number of well baby checks, or the caps on the number of new patients, because we're trying to bring some order out of the chaos. And so we have multiple appointment types, multiple appointment times, and frankly, it just adds to the chaos. But we're trying to improve this. We're just not exactly sure how to. We're constantly juggling urgent and routine. And patients call back and they're juggling urgent and routine. If they get a sense that if I make these symptoms sound a little more desperate, then they'll get me in sooner. And in order to come up with capacity, once we've overbooked and double booked and done as much as we can, we start to move patients obviously into the future, or to a colleague, or to the walk-in clinic, but over there somewhere. What happens inevitably is that continuity is sacrificed and care is delayed. We just simply can't match patients with the PCP when we're in a traditional model where the schedules have been jammed for days or weeks or even months. And so out of frustration with that model came what we now refer to as a carve-out model. And this really came out of the work of Mark Smoller, who was a pediatrician in Northern California. And he said, you know, we have enough information out there in the world to predict demand for urgent care. Again, using a medical model, medical definitions. We can look back and predict. And what he said was, if you have 10,000 patients and you want to have enough slots for urgent care, with 10,000 patients, you'd need 55 appointments on Monday, 50 on Tuesday, and 45 on each of Wednesday, Thursday, and Friday. And you could potentially extrapolate up or down, but based on tons of data that he analyzed and looking at urgent demand, he said everything else is left for routine care, and that'll give us enough for urgent demand. So what lots of us did was reserve space or carve out space or free space or appointments in anticipation of same-day urgent demand. And inevitably, our routine appointments got delayed, and patients who didn't fit a neat category, it's not really urgent, it's not really routine, we had to, again, we found ourselves overbooking and double booking. So let's say you've got a 3-week delay for routine care and you don't have any urgent slots, you can't give those away. So where in the world are you going to put somebody that you want to see in 10 days because you're starting a new medication? So literally, thousands of groups around the country have done this, have tried it, and it was a huge leap forward. But what we found is that these systems start to collapse on themselves because we're still relying on this urgent routine paradigm, and this model doesn't take into account understanding total demand. So ultimately, continuity suffers, and future capacity, if you look at a schedule, it's either filled or we're holding it in anticipation of same-day demand. So it works for a while, but generally tends to degrade over time. So it was out of frustration with that model, because we had worked that model for years, and we just kept finding ourselves sending more and more and more people into the urgent care venue to meet it. We actually started what we call the advanced access model. And we figured if Smoller could figure out demand for urgent, why couldn't we figure out total demand and get out of the business of trying to define urgent versus routine? We looked for evidence of a stable reservoir. It wasn't always the case, but you know, what was our delay? What was it a year ago? And how might we, you know, what did that tell us? We knew we had a gap. In our case, we had about a 45-day delay, and how were we going to get rid of that delay and or a backlog? And so we'll talk in a few weeks about how the strategy for doing that. But because we worked down this backlog of 45 days in our case, every provider, the expectation was that every provider had capacity every day they were in the office, not because we were freezing it or holding it and then releasing it the day of, but because they were now doing today's work today and it wasn't drifting into the future. So we found ourselves really motivated to pull as much work into today as we could versus pushing it into the future, which had been our survival mechanism. That's how you deal with a traditional model, is you push some of the work into the future. Some fears emerged, and that was, would we ever get rid of our saturated schedules? We believed demand was insatiable, and we had concerns about panel size. So we needed to look at and address all of those things. And what it really came down to is that, yes, indeed, if you have too large a panel, this isn't going to work. But the biggest problem, not only for us initially, but for most groups we've worked with since then, is that there's a lack of, or there's too much supply-side variation. We know what our demand pattern is, but for whatever reason, we fall short on the supply side. And so we really got busy on figuring out, okay, how can we soften that? How can we mitigate that? So again, in traditional and carve-out models, in order to protect today, we push work into tomorrow. In advanced access, in order to protect tomorrow, we actually pull work into today, because that's what's going to allow our future to be open and available for booking. Now, this is a laundry list of some of the things that came about as a result of advanced access. Obviously, reduced delays, also reduced urgent care and emergency department visits, improved continuity, better clinical outcomes, enhance compliance with clinical guidelines, reduce no-show rates, growth opportunities, and actually better financials for groups and satisfaction. And so I've got some slides here. I'm not going to go through all of them. You can look at them at your leisure. They're pretty interesting, and these are quite characteristic of the groups we work with. We were particularly pleased to see this drop in emergency department visits, because so often that's sort of the place where our patients default. So not going to spend time on this, but I do want to make a comment about this drop in overall demand when we line up continuity as well as access. Now, well, these are the high leverage changes that we're going to be drilling into, the 6 high leverage changes for access. You know, today we've talked about what is it, how does it compare to other systems, but our calls coming up down the road are going to really get into the nitty-gritty strategies for balancing demand and supply daily, reducing that backlog or that gap between where you are today in terms of delay where you want to be. How do we effectively decrease appointment types and times, and what's the advantage to that? How do we develop contingency plans on a day when things go wrong? How do we, in advance, plan for contingencies? How do we reduce demand for visits, and how do we optimize the care team? So those are the things that we're really going to be focusing on in our future calls. I think the next few slides are pretty redundant. We've talked about these things, and so what I really want to do is open this up for questions and comments. Again, whether it's in your measurements, whether it's you know, what we've talked about today. Let's take the remaining time and see what questions or comments folks have.
Again, if you have any questions, feel free to raise your hand, and I'll unmute your phone line, or you can chat your question into the chat function. I'm not seeing any questions right now, but did want to go back to Connie, Andrea, Javier, and Sarah, and just make sure that their questions were answered, and ask if you guys have any follow-up questions. Here's a question coming in now from Yvette. She asks, how do you address the fear that new patient appointments might crowd out established patient appointment availability? Mm-hmm. If we open up new patient appointments to all who call, a provider would be exhausted with too many new patients in a day.
So one of the things you might want to do, Yvette, and that's a great question. You know, we are acutely aware of the patients that are new to us, but we often don't recognize that patients, frankly, every month are leaving as well for a variety of reasons. And whether that's in balance or not is, you know, we simply don't know. Where I would start is I'd look at panel sizes. What are your current panel sizes? And are patients fairly and equitably distributed among your providers? And keep in mind that if you're currently booking, it sounds like you may have some restrictions on new patients, and that's fine for now. But if you look at, again, at your total demand, well, you may want to keep a tab on the number of new patients that are requesting appointments. But again, the problem is a new patient may call several times, so you don't necessarily want to count them in your total demand, because they really only are going to want that one initial appointment and then be established with someone and continue with them. So I would say take a really good look at your overall demand numbers, because that will include, you know, urgent, routine, and new patients who actually get an appointment. And then see what's left over. You know, these may be your deflected patients. It's hard to say. Or you may have, you may want your receptionist for a couple of days or even a week, or to keep track of how many new patients are calling, so that you have a real objective sense of what is the new patient demand. Because often what we find is that it's, you know, it is what it is, but let's look at the number and see see, is that something we can accommodate or not accommodate? Because if it's far beyond the scope of your ability to accommodate, then we've got to come up with leadership and sit down and talk about, okay, how do we want to manage this? But I'd say get an objective count of what that number actually looks like and what it is. The issue of being overwhelmed with new patients, you know, if you're a new provider, every patient's going to be new to you for a while. And so what we often suggest is, and new visits, you may make a decision that new visits should take longer than return visits. Some people do that, some people don't. But for a new provider, it kind of makes sense while they get used to all of these new patients and the patients get used to them. And what often people will do is hold every other appointment so that they actually have the time to get to know patients. But I would say look at the numbers. What do the numbers tell you? And recognize that ultimately that demand number is going to include everything. The other thing, and this I would say the third strategy would be to think about what makes a new patient visit difficult, and what can the care team members do to make that easier so it's not such a daunting task. So those are all things to think about, but it's a really, really great question. I want to be respectful of your time, but let me just quickly bring this to your attention. This is a table for a potential table for sequencing your advanced access project, to impanel your patients, to set an aim or a gold standard, to do your measurements, you know, delay, demand, supply, and so on, all the things we've talked about. And then these are the 6 high leverage changes that we're going to be going into great detail about over the next 6 or 7 weeks or so. And remember, at every step, and we'll bring this sequencing table up certainly again and again, but one of the important things is to continuously track and measure your data and to remember to celebrate both your successes and your failures. This is hard work. It's challenging work. It's incredibly rewarding work. And so we want to make sure that we take time to celebrate and enjoy the journey. Just a quick reminder, we're going to have our coaching Q&A call next week on the 7th. And again, we'll be able to drill further down into any questions that you have about anything that we've covered so far. Or if you've got questions about the article or any of the information sheets, we'll really be focusing on that. So at this point, I think I will turn it back over to Jarrett, and certainly thank all of you who have participated, and particularly those who were brave enough to ask questions and share their thoughts. Thanks, everyone.
Great. Thanks, Catherine. And thank you all for participating on today's conference. As usual, a link to the recording of today's webinar will be available soon in the Virtual Learning Lab. And I did want to mention that the Virtual Learning Lab is undergoing a redesign to better meet your needs. The HIV training package is still accessible for the time being through the drop-down menu of the second tab from the left, which is now titled Curriculum Menus. In the near future, the menus will be embedded into the lab pages. Now you're also going to notice a tab titled Clinical Webinars that contains information from past webinars. And those are for the clinical webinars. So we've also made a tab called Performance Improvement, which has been added, which contains a drop-down menu including a selection titled Increasing Access, which hosts these webinars, the advanced access webinars, as well as the resources and the links to all the webinar recordings. So that's sort of the one-stop shop for all the webinar recordings and materials and slide decks. And as Catherine mentioned, the next webinar is scheduled for February 7th at 1 p.m. Eastern Time. And just as a reminder, you can contact Catherine by email at ct@tantauassociates.com. And thank you once again for your participation, and hope everyone has a great rest of the day.
Thanks, everybody.